Today's webinar is the first in a series hosted by Osteoporosis Canada called FLS Works. Today's topic is the post-fracture care gap, the hard lessons from evidence and experience. And our guest speaker is Dr. Diane Theriault. Diane is a rheumatologist from Dartmouth and an osteoporosis specialist. She is the medical lead for the Fracture Liaison Service, or FLS for short, in Nova Scotia. She is also a dedicated Osteoporosis Canada volunteer for several years, both at the national and local level. And in 2014, she was the recipient of the O.C. Lindy Fraser Award for her outstanding leadership and contributions to the organization. In her current capacity, she is the Chief Scientific Officer of FLS with Osteoporosis Canada, and she is helping to facilitate the implementation of FLS across the country. So, without further ado, I'll pass it to Diane to get us started. And we are recording this webinar today, so we'll send it out after we're finished. And if you have questions, feel free to just type them in as we go, and we'll save them till the end, and I'll make sure that Diane gets those questions. All right, so I'll pass it to Diane.
Okay, so thank you everyone for joining in. This is the first of several webinars, and the topics I'm going to cover are the post-fracture care gap, which I think most of you are probably familiar with, and if not, I think most will agree that once you hear about the care gap, it compels you to want to act on it. I'm also going to talk about the solutions, and you'll see that I've put the solutions in brackets, and that's because I've been given a very difficult task of going over the non-FLS solutions, which you will see are not always as effective as we would like, and surprisingly so. So I'll be going over the non-targeted interventions, and in the targeted interventions, I'm going over mostly the 0-eye and the 1-eye models. So how likely are we to break a bone? Well, 1 in 3 women and 1 in 5 men will break a bone during their lifetime, and the overwhelming majority of these will be due to osteoporosis. And the consequences of fractures are devastating. So this is the consequences of hip fractures, one of the most devastating osteoporotic fractures. And as you can see, less than half of the patients who break a hip ever recover the full level of independence that they had prior to their broken hip. Close to 1 in 5 will need to be transferred to a long-term care facility. 23% of women and 36% of men will die within that first year following the broken hip. But I want to focus on the issue that fractures beget fractures. So after a broken wrist, 14% will return with another broken bone within 3 years. But fractures, osteoporotic fractures, are not created equal. And after a vertebral fracture, 1 in 5 will have a second vertebral fracture within 1 year. So that's a huge risk. And as you can see, with a broken hip, 9% will break the contralateral hip within the first year. 15% will break it within the next 3 years. And 20% will break the other hip within 5 years of the first broken hip. And as you can see, if they don't break another hip, they're going to be coming back with some other broken bone. So it's clear that fractures due to fragility are a huge flag for a future fracture risk. We wouldn't be here if we didn't have adequate treatment, and this is just a real quick summary of the fact that we have very effective medications. So to prevent spine fractures, we can reduce the risk by 59 to 65% within 1 year of initiating treatment. To prevent broken hips, it takes a little longer, but the fact is within about 40 to 50% decrease in fractures. And I wanted to illustrate the fact that we can actually reduce the fractures, even hip fractures, relatively quickly. So this is from a denosumab randomized controlled trials in women. And as you can see, you can appreciate that at some point between 6 months and 12 months, you can see that the survival curves to first hip fracture do differentiate quite nicely between placebo arm and the denosumab arm. So to summarize, we really have medications that are not perfect, but they work relatively well and relatively quickly. So therefore, it's no surprise that our current Osteoporosis Canada guidelines do say that a fragility fracture in an individual over the age of 50, it really needs attention to osteoporosis care, and we recommend a BMD and or treatment. Now, this is not controversial guideline. In fact, if you look at all national and international osteoporosis guidelines, currently, they all sing this tune. And although we've tweaked this tune somewhat over the years, that mantra of fragility fracture means BMD and or treatment. That's been the mantra that's been there with Osteoporosis Canada since the 1996 guidelines. That mantra really has not changed. So obviously, it looks like a simple problem and a simple fix. Surely we must be very good at this by now, and the fact is we're not. So this is data in women who had fragility fracture in Quebec. And as you can see in blue, 15% of the women did receive osteoporosis treatment. 5% in yellow had a BMD test but were not offered osteoporosis treatment. And that was probably appropriate care because not everyone who has a fragility fracture requires osteoporosis treatment. But the fact is that that blue and yellow, that's a very small portion of this pie. The most important portion of this pie is the 79% of patients who had absolutely diddly squat done. So no screening, no diagnosis, no treatment, and really no hope to prevent their next fracture. And I think you'll see in future slides that it's always in the 75 to 80% care gap when we look at this. So this, by the way, was published in 2008, but it was 2005 data. It's a decade later now. We must have gotten better. And we have more recent data from Quebec. And we're going to follow the purple squares. This is the proportion of men and women after the age of 50 who received an osteoporosis treatment following their fracture, so within 1 year of their broken bone. So you can see in 2000, 12% were treated, so that's an 88% care gap. And in terms of over time, you can appreciate, I think, the fact that over time you see an improvement up to a big whoopie ding 16%. And you can see that that then plateaus. But then in 2010, you can see a slight drop over time. And that's alarming, and that's in fact the care gap as well as the worsening of the care gap post-fracture is a universal phenomenon. So here's some data post-hip fracture from the US, and you can see that the rate of treatment of hip fractures with osteoporosis drugs has declined from 40% in 2002 down to 21% in 2011. Excuse me. So what's happening to these patients? Well, they get lost in what's been known as the Bermuda Triangle of osteoporosis care. So who's to blame? Well, these fracture patients, nobody is even suspicious of their underlying osteoporosis, so they won't be referred to me or to another osteoporosis specialist. Excuse me. So obviously I can't be held responsible for these patients because I'm never going to see them. The orthopedic surgeon, their job is to fix the fracture, and they do an exemplary job of that. And so consequently, they've done their job and they're not to be held to blame for the lack of osteoporosis care. And it might look like it falls under the primary care physician's bag, but the fact is that we know that most acute fracture patients do not go see their primary care physician. They get their acute care, their analgesia, their physio, their rehab at the hospital under the care of the orthopedic surgeon. So they can't be to blame either. But the fact is that the patients do get lost in there. So what does that mean for the patients themselves? Well, we know that fractures beget fractures, and we know that they're not getting diagnosed and not getting treated. So when a patient breaks a bone, they enter into what we call their osteoporosis career. So here's an example of a patient. So 55-year-old woman who ends up with a trip and fall and breaks her wrist around the age of 56. Nobody's the wiser about her bone health, and so she goes on to have her first vertebral fracture, and then a second vertebral fracture, and then a third one. And at 82, she then graduates and ends up with that dreaded broken hip. And as you can see, that osteoporosis career has spanned here a good 30 to 40 years, and not once did the light go on in the system. And the fact, these patients are abundant. They're the average fracture patients out there. They're caught in this osteoporosis career. If we look at it from the other end, from the patient who has broken a hip, in fact, 50% of them had already warned us they would be coming because 5 years ago they broke their wrist, or 3 years ago they broke their shoulder. But we didn't do anything, and so they're coming in with that broken hip. So, simple problem, simple fix. The care gap is compelling, and many individuals have been spurred on to try initiatives, pilots, projects, interventions to try and close that care gap. I'm not a researcher, I'm just a regular clinician. And in fact, I've been at this for a long time. So this was my very first attempt to close the care gap. We did a pre-survey of fragility fractures of the hip, wrist, and shoulder at my hospital. It's a small hospital. Over the course of 2 months, we saw about 54 patients. We did a survey. 20% of patients had a BMD test, and 41% had an osteoporosis treatment. By the way, 1998 was still in the era of the estrogen, and so that high number on treatment is in large part because some of the women were already on estrogen prior to their fracture. We did an intervention where the radiologists sent out a more aggressive report in the subsequent 2 months on the fragility fracture patients, indicating that the patient likely suffered from severe osteoporosis and that bone density tests should be done and that, if needed, treatment be started. So here's the post result. And as you can see, for the next 2 months while we did the interventions, we really got very little success. In fact, this is an abysmal failure in terms of improving the care that the patients receive. So I want to go over a number of interventions that have been done in Nova Scotia to illustrate what's happened in my province. But I'm pretty darn sure that in most provinces you can find the same kind of history of many pilots and many interventions that have been done. So before my time, there was an endocrinologist who had attempted a model where the orthopods were supposed to refer all of their fracture patients to the osteoporosis clinic, and that failed. There was also a model where he hired a nurse to look after hip fracture patients that were admitted, but they soon ran out of funding, so that failed because of lack of funding. In 1998, we started at my hospital a patient education program for osteoporosis. In 1998, that was my project that failed. In 2000, our osteoporosis patient education at Dartmouth went province-wide. via telehealth, and it's available at all 40 hospitals in the province. In 2002, there was a big survey of hip fracture patients in Cape Breton, and they realized then that there was a huge care gap and that less than 10% of the hip fracture patients ever received the diagnosis of osteoporosis. And so that led to some further interventions, as you'll see. At the same time, our Department of Health engaged into a big, massive project on osteoporosis with 13 recommendations, all of which were endorsed by the Minister of Health. And the next year, one of those recommendations was Nova Scotia-specific osteoporosis guidelines. And of course, you can't see this, but it says if there's a fragility fracture, they needed to have a bone density test. So that's in compliance with what we said. In 2003, we did academic detailing in Nova Scotia. If you're not familiar with academic detailing, that is one-on-one education with the family physician in their own office, and that and these physicians committed at least 20 to 30 minutes for this. And one of the key messages was, if they have a fragility fracture, BMD and or treatment. And we visited over a third of the family physicians one-on-one. That is a huge education initiative. In 2004, an orthopedic surgeon in Cape Breton hired an ortho tech to phone the fragility fracture patients. And there was an alert letter that went to the family physicians, but that had to shut down because of lack of funding as well. In 2004, they hired the one and only ever bone health coordinator in the province, who worked for 3 years at helping educate the general public and the patients with osteoporosis in the community. I had not learned my lesson with the radiology project I did at Dartmouth General Hospital back in 1998, and I attempted a similar project in Cape Breton for 3 months, and we got the exact same results there. So it was a failure. And this one here in 2006, that is my absolute worst ever failure. This was the biggest project I was involved with. We had designed a beautiful brochure to educate the patients. We did education of all the departments involved with fracture care at our hospital. We developed some templates for letters to go out from the emergency department, from the orthopedic clinic, from the orthopedic staff in the inpatient fracture patients, and from the X-ray department, and that completely failed. In 2007, we did a 6-hour course on osteoporosis, and you need to realize that Nova Scotia is a small province. So when I say that 162 healthcare professionals attended this course, this is pretty massive. This was a project where we tried to educate the politician. I don't need to tell you that that failed too. We did a second round of academic detailing in 2009. Again, over 300 family physicians visited one-on-one. This was over a third of all of the family physicians in the province. Another big course, this was a full day 8-hour course, 99 attendees for Nova Scotia. So that's, again, a huge turnout for our small province. There was an audit of the osteoporosis care in fracture inpatients at the Annapolis Valley Hospital in 2010. As you can see, the rate of treatment was still abysmal. 2011, the Department of Health partnered with the Cape Breton District Health Authority to try and incorporate the guidelines into the protocols of the hospital. There was huge, massive education, and there was a partnership with Health Transformation Office, etc. And that really did not lead to any change in treatment. At the Halifax Infirmary, there was a project where nurses did some education to patients, and they ended up with 24 of patients on treatment at 6 months, so still a very low rate of treatment. And in 2012, the Department of Health decided to do a big, massive chronic disease target setting project, and osteoporosis was one of the selected diseases. And as a baseline to this, the one and only province-wide measure of the care gap was done. So this is a care gap measure in 2012 after 15 years of lots of interventions within my province to try and close this particular care gap. And this is where we stand in 2012. And as you can see, 23% of the hip fracture patients receive osteoporosis treatment. And by the way, that is what the guideline says since 2010 for fragility fractures of the hip. And our care gap is similar to all the other provinces and other jurisdictions worldwide, where, again, 77% of the hip fracture patients in Nova Scotia did not get the care they need to help prevent their next broken bone. So there are some lessons to be learned here, and the hardest one of all is this one, is that I'm a very slow learner. Obviously, it took me 15 years to see the light, and my hope is that for any of you here who are planning to close this care gap and planning some projects, at least that you'll go in with your eyes wide open as to some of the limitations of some of these interventions. Because we do know what works and we know what doesn't work. So let's be smarter about this and let's look at the science. And we have tons of publications that have been published. So if we're going to be smart about this, we should look at what outcomes we should look at. So obviously, if we want to close the care gap, that presumably means that we're going to see more BMD tests done and more osteoporosis treatments prescribed. And because osteoporosis medications are effective, we will then see a decrease in fractures, including those dreaded broken hips. And we know that those hip fractures are both deadly and costly, and hopefully we can see a decrease in those as well. Now, I want to point out to you, though, that the BMD is a little bit of a red herring, because if you have an intervention that ends up even with 100% of the patients getting a BMD test, but no one ever gets started on an osteoporosis medication, then there's no hope of ever decreasing their risk of their next fracture. So there's no doubt that the first critical step that an intervention needs to prove is that they can increase the rate of treatment of the fracture patients. The other thing we need to look at is how we can divide up the types of interventions. And as a general comment, we divide them up as non-targeted or targeted interventions. So the non-targeted interventions are things that try to alter the patient's outcomes without directly connecting with the patient. So for example, when I talked about the academic detailing projects that we did, that was educating the family physicians in the hopes that then the care of the fracture patients would improve. So that's a non-targeted intervention, as opposed to an intervention where we actually saw the patient. So for example, the one I did at Dartmouth General with the radiologist, that was connecting directly with the fracture patients. So let's look first at the non-targeted interventions. Well, I won't go over the studies, but we've done tons of them worldwide. Clinical practice guidelines have made not even a dent in the post-fracture care gap. Knowledge translation tools, updates in the literature, trying to integrate the guidelines into the hospital protocols, or adopting clinical order sets, they've all failed to close the care gap. Education, no matter how intensive and no matter whether we target it to family physicians, orthopedic surgeons, radiologists, the osteoporosis patients, the fracture patients, the general public, they all fail. And ads on TV, and some of you may remember the days when Sally Fields was doing some promotion of fracture care and osteoporosis care. None of these have had any sort of impact on the post-fracture care gap. So let's look then at the targeted interventions. Well, the targeted interventions are so broad in themselves that we've subcategorized them. So let me go over how we subdivide them. The fact is that some of these will capture the patient, so they'll identify the patient. They may do education on the patient, but if no alert goes out to the family physician and that's all that happens, those are considered zero-eye interventions. If the model captures the fracture patient and sends an alert to the family physician, that's considered a one-eye. If the model captures the patient, alerts the family physician, and does a BMD on top of things, that's a two-eye model. And if the model captures the patient, does a bone density, prescribes the treatment itself, and then sends an alert to the doctor, that is a three-eye model. So let's have a look at some interventions. And this is a very brilliant intervention done by a good buddy of mine from Manitoba, Dr. Bill Leslie. And this is a study that I've got to say it's a very logical, rational, very well thought out study. And I think you'll all agree that in our heart of hearts, we have to believe that this is a no-brainer and would work. So this is a randomized controlled trial of men and women over 50 with a fracture. There are three arms to this study. So the usual care arm, which is they really did nothing but capture the data. The family physician notification arm, the patient's family physician receives a letter that reads something like this. Dear Dr. Smith, your patient Annie White broke her wrist last month. This may be the first warning sign of osteoporosis. It is recommended that you do bone density tests and if needed, start them on treatment. In the third arm, the family physician still gets that warning letter, but the patient also receives a letter of their own. So it says, Dear Mrs. Annie White, you know that broken wrist you suffered last month? That may be your first warning sign of severe osteoporosis. Please book yourself in to see your family physician. You may need a bone density test and you may need osteoporosis treatment. So those are the three arms. And if you look at what type of model in terms of zero-eye, one-eye, two-eye, three-eye, these are both one-eye models. So this is a little bit more intensive because there's a very strong zero-eye component, whereas this one is just a family physician. So this is also a big study, so there's no doubt that we can believe the results. So usual care, this is their primary endpoint. BMD and or treatment, 13%, that's no surprise. So how did the intervention arms fare? So I want you to digest this data. This is a statistically significant improvement. So this is very important to note. But on the other hand, I think you can still appreciate that the care gap is still alive and well in Alberta. But remember I said that the BMD is a little bit of a red herring, and the critical first step you need to reach is the treatment. And this is the result. Again, this is a statistically significant improvement. So this is good results, but again, I think you can appreciate how underwhelming this is in terms of meaningfully closing the care gap. I'm now going to just show you a more recent study that was done in Alberta that was a slightly different model, but still a one-eye model. So I'm going to leave the two boxes from Manitoba here. So this study was still a large study, as you can see, a large number of patients. Instead of just sending a letter to the patients, there was also a phone call to the patient, so a little bit more intensive. And I'm leaving the Manitoba data there just to show that a one eye and another one eye, how similar the results were. It's amazingly similar, as you can see. So we have so many of these interventions that we now have a meta-analysis. So not for the non-targeted interventions, but here we know that there was no benefit whatsoever on the care gap. And for the targeted interventions, the meta-analysis has really proven that there is zero benefit on the care gap from zero-eye models. And for the one-eye models, there is always consistently a significant improvement in the care gap, but mediocre at best, as we saw from the Alberta and the Manitoba models. This is not failure, by the way. We have now identified the 10,000 ways that will not work to meaningfully close the post-fracture care gap. We need to pay heed to this, because if we don't pay heed to this at all, we're going to just repeat the same errors that others have done before us. So why did we not get anywhere in Nova Scotia? Every single one of those interventions that I listed for you, they were all either non-targeted, zero-eye, or one-eye models. So this is the very discouraging part of my message here for you today. It will not be as simple as educating or trying to activate the patients. It will not be as simple as educating the family physicians or the orthopods, the emergency room physicians, the nurses. It certainly won't be as simple as sending out alerts to the patients or to the family physicians. You saw a good example of that. It won't be as simple as adopting a new clinical order set or trying to incorporate the guidelines within the hospital's protocols. And it certainly won't be as simple as asking the existing staff to divide up the post-fracture work that needs to be done. We need to really stop doing these one-eye and zero-eye, or at least move beyond that, because we need to go to the models that have proven effective. In the meta-analysis, there's no doubt that the effective models were the two-eye and the three-eye models. The models where there is a BMD test done and or the treatment is prescribed within the model. And in fact, these are the ones that we call fracture liaison services. Over and above that, the meta-analysis highlighted the fact that a dedicated FLS coordinator that's dedicated to just doing this work is central and pivotal to the successful fracture liaison service. This is Osteoporosis Canada's definition of a fracture liaison service, which is well in line with the GANDA meta-analysis. So a fracture liaison service is a specific system-based model of care for secondary fracture prevention where a dedicated coordinator systematically and proactively identifies patients over 50 presenting to hospital with new fragility fracture. The FLS must organize the investigations to determine the patient's fracture risk. And the model must at least facilitate the initiation of the appropriate osteoporosis medications. So the FLS must either recommend or even prescribe the osteoporosis medications. Now, this was our care gap in Nova Scotia, and I want to deconstruct that for a minute so that you understand where the FLS needs to be. So, who are those 23% of patients who are on treatment post-hip fracture in Nova Scotia? Well, they're actually patients that either their family physician themselves have identified these patients as high risk and have started them on osteoporosis treatment, or they were referred to an osteoporosis specialist, and someone like myself started them on treatment. So that 23%, they're the lucky people. They're the ones that are already getting good osteoporosis care. The FLS may indeed enhance the osteoporosis care they get, but that is not the prime objective of the FLS at all. The prime objective of the FLS is to capture these patients, the 77% who are not so lucky. And those 77%, they're already stuck in that Bermuda Triangle. So if you're a family physician with a practice, I'm going to guess that because you have an interest in osteoporosis, your patients are already in the 23%. And if you're an osteoporosis specialist, it's a guarantee that your patients are already also in that 23%. The FLS is to help the others, and where the others live are the orthopedic services. In fact, of all the FLSs in Canada, in 100% of the cases, there is an FLS coordinator that works in the orthopedic services to identify these patients. In 2013, at my hospital, after having had many failures, we have finally saw the light and we hired an FLS coordinator for my hospital. Within 1 year, and I want you to watch the blue, that's the lucky people. Within 1 year of the implementation of FLS at our hospital, 79% of the hip fractures have been initiated on an appropriate osteoporosis medication within 6 months of their fracture. And if we look at the high-risk non-spine fracture patients, again, same ballpark, 81%. So the bottom line here is that FLS does work. It doesn't take rocket scientists, but you need to do this the right way. We've identified what are the essential elements of an FLS, and they're mostly focused on the first eye, the second eye, the third eye, the need to communicate with family physicians, and the need to monitor outcomes. And at the present time, we have 41 FLSs in Canada, and as you can see, that is a very sparse number. We need a whole lot more. There are indeed 5 provinces without an FLS at all at the present time, but even the provinces with FLSs, there's still the overwhelming majority of the fracture patients are still not served by an FLS in those provinces. So we have a long way to go. The next few FLS webinars will be focusing on fracture liaison services and helping you understand exactly how those models work well. So at this point, I'll take questions, and I think if I'm correct, you can just write them in the chat box, and I will answer them.
Yep, that's right. Just go ahead and type them into the chat box. And while we're waiting for some questions to come, I'll just talk about the next webinar. So it's going to be on Thursday, June 1st. And this topic will be FLS, the effective model to close the care gap. Our speaker will be Sonia Singh. She's the medical lead for the FLS at Peace Arch Hospital in White Rock, BC. And she's also the medical director for research with Fraser Health. And registration for that webinar will be sent by the liaison newsletter, which you get if you're part of the FLS network. And I also sent a registration link in the follow-up email, which you'll be getting an hour after we finish today. You will also get a survey. If you could please fill that out, we would very much appreciate any feedback you have. I would also just like to ask if you have further questions to just email me. My email is also in that follow-up email. So we just had one question that came in while you were presenting, Diane, and that was if you were willing to share your slides.
Okay.
A couple people asked me that.
Yeah, so I'm probably willing to share my slides only to those who participated. As you can imagine, all those Nova Scotia slides, unless you understand what I was saying about them, you might not understand what they're really meaning. So if you've attended this and would like to look at this again, certainly. And we will be posting this webinar on the OC website. So if that does the trick for you, that'd be great. Certainly, if there are certain slides you'd like to use for your own presentations, as long as I know which one and you understand the purpose of the slide or the meaning or the intent of the slide, then I'd be okay to share that as well.
All right, so we had a question come in from Alan Lowe. Says, some orthopedic surgeons are not convinced that prescription therapies prevent fractures despite the evidence published. This makes it hard to organize an orthopedic fracture coordinator. Any advice or suggestions/comments?
Yes, that is a difficulty. We do face a lot of challenges, and that certainly is one of them. So there's no doubt that the best place to locate the FLS coordinator is the orthopedic services. Emergency department might be another place, except the patients are in acute pain. They're on high dose of analgesics. They are not going to remember anything the FLS nurse would ever tell them in that setting. It's just not an appropriate setting for the FLS to do their work. But the orthopedic clinic and the orthopedic ward are the prime locations. I must say that if you cannot, it is the absolute must that you at least get the support of the orthopedic surgeons. And at my hospital, it meant that I met with all of the orthopedic surgeons one by one first to get they enlist their support. At my hospital, they were not opposed to osteoporosis treatment. Their major barrier was mostly that they did not want to have to do anything. So they said, listen, Diane, you could go ahead and do whatever you want as long as you don't ask me to do anything extra other than what I'm already doing. They were quite okay. And certainly you do not want your FLS coordinator to slow down the patient flow in the orthopedic clinic, for example, because that would be a definite no-no. So there are now tons of models, and we know how to not slow down the patient flow in ortho clinics. Some orthopedic surgeons have reservations in terms of the possibility that osteoporosis medications may impede fracture healing. And in fact, there is no data that really supports that. So it's a matter of just giving them the evidence, and in my experience, that convinces the orthopedic surgeon on that front. There are some orthopedic surgeons who are concerned about the possibility of the patients developing atypical femoral fractures, and the fact is that their risk of having the contralateral hip broken, for example, is so much higher than the very, very, very remote possibility of atypical femoral fractures, although that is a true concern, but it is so minimal compared to the frequent repeat fractures that occur. There are some orthopedic surgeons, though, who are in the minority who do not believe in osteoporosis. There are some orthopedic surgeons who believe that the fractures are caused by the fall, not by osteoporosis. And for sure, the two contribute to the problem, but our bones were meant to walk and run and jump, and our bones were also meant to fall and for us to pick ourselves up. And when we fall and we break a bone from a simple fall or a simple trip, that is the bones failing us. And I don't think that all orthopedic surgeons realize that. But if you have an orthopedic surgeon at your hospital who's totally opposed to osteoporosis treatment, I must say that that is a huge barrier. In 2017, there are still very few FLSs. I think if we go forward 5 years from now, FLS will be standard of care. Those orthopedic surgeons will not have any choice but to accept that FLS will be happening at their hospital and within their clinics and within the orthopedic wards. But for right now, I would say that in hospitals where you have a really opposed to FLS and opposed to osteoporosis orthopedic surgeon, you're probably fighting an uphill battle to try and implement an FLS at that hospital. So I'm afraid that I don't have an easy solution for you, except to be patient and sort of wait till it becomes more accepted in surrounding hospitals. At some point, the pressure will be there for them to also implement. I hope that helps you. I know that's not a perfect answer, but there's no easy answer to your question.
Thanks, Diane. There was 3 more questions that came in. So the next one was from Dr. Mulholland. He asked, Diane, are 79% of your patients on either a bisphosphonate or Prolia?
Yes, so the patients that are on effective treatment, they have to be on either, they could be on estrogen, okay, but there's not too many of them, on a bisphosphonate, they can be on denosumab, and they can be on teriparatide. Those are the ones we consider on effective treatment. We do not consider patients on raloxifene or etidronate as being on effective treatment because we only consider the medications that are first line as per Osteoporosis Canada 2010 guidelines. So I hope that answers that question.
All right, the next question was from Monica Gozel. It's, in your setting, is the FLS coordinator set up at an outpatient clinic, actual office space / assessment space? Also, is documentation done as outpatient or acute care setting? Any pros or cons noted in the way things are set up in your hospital setting?
So in my hospital, the FLS nurse has an office, but it is not in the orthopedic clinic. It's actually not even on the same floor as the orthopedic clinic, so it probably takes her about 3 or 4 minutes to get from one place to the other. So that is, the closer their office can be to the clinic, the better it will be. Now, I'm not sure that I got what the second part of her question was.
Also, is the documentation done as outpatient or acute care settings?
So the documentation, my FLS nurse has her own chart for patients. And you need to understand that my hospital does not have a very good IT system. So there is no EMR at this point or HR for the orthopedic clinic yet. So they have the scheduler, but there's no, everything is still on paper. I know that's archaic, but it is the way it is. So all of the data is collected on one form. It's about 4 pages. And it is when she's finished with the patient, she sends that to medical records, and that's scanned into the patient's record. It becomes part of the patient's chart. But that's essentially at the time that we discharge a patient from the FLS. Ideally, if you look at Ontario, it's all done on that they have very good electronic system for the Ontario Strategy FLSs. The FLS coordinators have a tablet, and all of that, when they enter the data in their tablet, it just feeds in to their central database automatically, which to me, that's an ideal kind of setup. But I think most FLSs will have to work within the confines and limitations of what they do have for IT. So for example, in Nova Scotia, we are in the process of implementing other FLSs, and the hospitals don't all have the same IT systems. They don't even speak to each other. So obviously, if we're going to have a common database, we're going to have to establish our own outside of the hospital's IT systems, because hospital in Kentville does not talk to a hospital in Dartmouth. Their systems just are not compatible. It's just the nature of the beast.
So there was another question from Tracy Graham. Can you provide links to models to prevent slowing of ortho clinic flow? And do you provide ZA, I'm thinking that's zoledronic acid, or Prolia in post-op clinics, or what is the optimal time to start ZA or Prolia in post-op hips? Thanks.
Okay, so let's start. Can you deconstruct that question, because there's too many things there?
Yeah, so the first one was, can you provide links to models to prevent slowing of orthoclinic flow?
So in terms of that, I think the best way we can do that is if you're implementing an FLS, we can provide mentorship. So we can connect you a linkage with another FLS that's similar to yours. So if you're implementing an inpatient FLS, we could connect you with another FLS coordinator from another inpatient FLS, or outpatient with an outpatient. And hopefully we can get you to sort out how the tricks to try not impede patient flow anywhere. So hopefully that would help.
The second part of the question was, do you provide ZA or Prolia in post-op clinics?
Do we provide, sorry?
ZA, I guess that means zoledronic acid.
Oh, zoledronic acid, okay. So no, so in our orthopedic clinics, there's about 80 patients flowing through in a half-day clinic. So no, there's no way that we can provide the Prolia or the zoledronic acid in our clinic. And our hospital does not even have zoledronic acid on formulary. So that's not an option at our hospital. In fact, my FLS at Dartmouth General Hospital is a 2I FLS, so the treatment is initiated by the family physician after the FLS coordinator sends out the recommendations as per Osteoporosis Canada guidelines. So it is done through the regular route. So denosumab or Prolia would be administered by the family physician themselves. And I can tell you that in our orthopedic setting, the orthopedic surgeons would not be receptive to even my FLS nurse administering the Prolia. They don't want to take on that responsibility in their clinic. So plus it probably would slow down the patient flow. So not likely to happen that way, although I could certainly see that this would be a great way of providing point of care to the patients. There was a third part to that question.
Yeah, the last part of that was, what is the optimal time to start zoledronic acid or Prolia in post-op hips?
Okay, so the optimal time is right away, as soon as possible. And in fact, if a hospital was able to have zoledronic acid on their formulary and could actually administer that prior to discharge, that would be awesome. There is no point in delaying that. So if you look at zoledronic acid, that's been well looked at. There's no decrease in or any change or slowing down of fracture healing, no worsening of non-union or delayed union in patients who receive their zoledronic acid within 1 week, within 1 month, or within 3 months of the hip fracture. So the fact is there's no point in delaying. The highest risk after a fracture to have a second fracture is that next 12 months. So the very quickest you can initiate, the better. So, you know, ideally you want them all to be started very soon.
All right, then that was the last question. So I think we're finished. Thank you, Diane. And thank you, everyone, for joining us today.
Yes, and we would appreciate your feedback. And apart from my cold and my voice that's been faltering here, we would certainly appreciate your comments on the technical quality that you received, as well as the information that you received. So that would be great to get your feedback. So thank you very much.
A survey and a recording of the webinar will be coming to you in about an hour's time. So thanks, everyone. Bye now.